Thoracic anesthesia. Indications for thoracic anesthesia. Thoracic anesthesia is required for a wide variety of surgical procedures involving the chest cavity. Indications for thoracic anesthesia. Thoracic anesthesia is required for a wide variety of surgical procedures involving the chest cavity, mediastinum, and lungs. These surgeries often necessitate lung isolation, lung ventilation, and careful ventilatory and hemodynamic management. Common surgical indications: lung resections, lobectomy, segmentectomy, pneumonectomy, video-assisted thoracoscopic surgery VATs. Diagnostic or therapeutic: esophagectomy, lung transplantation, tracheal resections and reconstructions, mediastinoscopy, decortication for empyema, repair of bronchopleural fistula, spinal surgery requiring thoracic exposure, thoracic aortic procedures, e.g., descending aorta aneurysm repair. These procedures frequently require lung isolation to allow surgical exposure, prevention of contamination, e.g., infection, blood, pus from diseased lung. Protection of the healthy lungs, selective ventilation and CPAP application, improved operating conditions in a collapsed hemithorax. 2. Preoperative evaluation. Thorough preoperative assessment is critical due to high-risk nature of thoracic surgeries, prevalent cardiopulmonary comorbidities, anticipation of potential postoperative respiratory complications. 1. Respiratory function testing. PFT's objectives: assess baseline pulmonary function, determine operability and resection tolerance, predict need for postoperative ventilatory support. Key parameters: FEV1. FEV1 is greater than 2L, low risk for pneumonectomy. FEV1 is greater than 1.5L, acceptable for lobectomy. DLCO, diffusing capacity for CO. Assesses gas exchange capacity, crucial in patients with ILD or emphysema. Predicted postoperative FEV1 formula: PPO FEV1 equals pre-op FEV1x, 30% equals high risk 6. Minute walk test, 400 meters equals good functional reserve. 2. Cardiopulmonary reserve testing, used when borderline PFTs or high surgical burden. VO2 max via CPET, cardiopulmonary exercise testing. VO2 max, 20 ml/kg min, low risk, 10-15 equals moderate risk, 10 ml/kg min, high perioperative morbidity, mortality, 20%, simple bedside tests, stair climb test, climbing, 22 meters, 5 flights. Is reassuring. Borg scale dyspnea assessment during exercise. 3. Arterial blood gases. ABGs. PAO2, 60 mmHg on room air suggests impaired oxygenation. PACO2, 45 mmHg predicts higher likelihood of postoperative ventilation requirement. 4. Imaging and anatomical assessment. Higher resolution CT chest, surgical anatomy, resectability, mediastinal invasion. PET CT, for staging, nodal involvement. Bronchoscopy, identify airway lesions, assess for endobronchial growth. Echocardiography, to evaluate for pulmonary hypertension, RV dysfunction. 55 function. 5. Smoking cessation, at least 4 weeks cessation, sputum production, improved ciliary function, ideal equals 8 weeks, associated with lower postoperative complications. 3. Preparation for thoracic surgery. Thoracic surgeries involve major physiological shifts, require lung isolation, and have a high risk of hypoxia and hypotension. Proper intraoperative planning and monitoring setup is essential. 1. Pre-medication anticholinergics, e.g., glycopyrrolate, reduce secretions especially for fiberoptic bronchoscopy, bronchodilators, in asthmatic or COPD patients, optimize airways, opioids and anxiolytics. Carefully titrated to avoid respiratory depression in patients with poor pulmonary reserve. Steroids, if airway reactivity or chronic use, e.g., transplant patients. 2. Monitoring beyond ASA standard. Thoracic procedures often require arterial line, invasive BP monitoring, beat-to-beat hemodynamics, frequent ABGs especially during OLV, central venous catheter optional, for vasopressors. Volume management in large surgeries helpful in complex esophagectomies or transplant patients. Temperature monitoring, long duration, open chest, risk of hypothermia. Urine output monitoring, major resections, especially if one kidney. Neuromuscular monitoring, ensures adequate paralysis, essential during OLV to prevent spontaneous breathing. Transesophageal echocardiography, TO, consider if major vascular involvement or pulmonary hypertension. 3. IV access and warming, at least one large bore IV fluid warmers and body warmers to avoid hypothermia. Avoid unnecessary fluid boluses. Restrictive strategy needed. IV. Lung separation techniques. Lung separation or lung isolation is fundamental in thoracic anesthesia, enabling Collapse of operative lung, surgical exposure, protection of non-operative lung from spillage, selective CPAP or suctioning. 3 main techniques. 1. Double lumen endotracheal tubes, DLTs, the most commonly used and most reliable method of lung separation. Design: 2 lumens, tracheal and bronchial, 2 cuffs, tracheal larger, proximal and bronchial smaller, distal, can be left-sided most common or right-sided, left versus right DLT, left-sided DLT preferred for most procedures because left main bronchus is longer and more stable, less risk of occluding upper lobe bronchi. Right-sided DLT only used if surgery involves the left main bronchus, but requires perfect alignment with the right upper lobe ventilation slot. Must confirm with fiber optic bronchoscopy. Advantages of DLT. Rapid and complete lung collapse allows suctioning of operative lung. CPAP can be applied to collapsed lung, allows easy switching between 1 lung and 2 lung. Ventilation more stable once placed correctly. Disadvantages. Larger external diameter difficult in patients with small or difficult airways, can cause laryngeal tracheal trauma, needs bronchoscopic confirmation, not suitable for awake intubation or anticipated airway difficulty. 2. Bronchial blockers, BBs used with a single luminette. These devices block a mainstem bronchus to isolate 1 lung. Common types aren't wire-guided BB, Cohen flex tip BB, Fuji BB, uniblocker, Fogarty embolectomy, catheter off-label. Technique: inserted via multiport adapter or bronchoscope port, advanced into target bronchus under fiber optic guidance, balloon inflated to occlude bronchus. Advantages: ideal for difficult airways, you can secure the airway with a net first. Can be used in pediatric patients, useful in tracheostomized patients, no need to change tube post-op for ICU ventilation. Disadvantages: slower and less complete lung collapse, no suction port in some BBs. CPAP application is limited, BB may dislodge with head-neck movement, needs frequent reconfirmation. 3. Univent tube, a specialized single luminette with an inbuilt blocker channel. The blocker can be advanced into the main bronchus and inflated. Advantages: combines the simplicity of ET plus bronchial blockade, can allow intraoperative conversion from SLT to lung isolation. Disadvantages: stiff and bulky, poor suctioning and CPAP capability, rarely used today due to availability of DLT and BB options. Indications for lung isolation. Absolute indications: must isolate. 1. Prevent contamination of healthy lung, massive hemoptysis, bronchiectasis with purulent sputum, lung abscess, unilateral infection. 2. Control of ventilation, bronchopleural or tracheobronchial fistula, giant bully or cyst, severe unilateral lung injury, surgical opening of a major bronchus. 3. Unilateral pulmonary lavage, e.g., alveolar proteinosis. Relative indications desirable for surgical exposure. 1. VATs procedures. 2. Open thoracotomy. 3. Lobectomy or segmentectomy. 4. Esophagectomy. 5. Thoracic aortic aneurysm repair. 6. Upper thoracic spine surgery. 7. Mediastinal mass resections. 8. Procedures where CPAP or suction to 1 lung is beneficial. V. Confirmation of DLT and bronchial blocker placement. Lung isolation devices, DLT or BB, must be confirmed immediately after placement and again after changing patient position, especially to lateral decubitus. A. Clinical confirmation of left-sided DLT. Full 7-step protocol from Table 25-2 of Morgan, incorporated from your uploaded image. 1. Inflate the tracheal cuff only, 5-10 ml air. Ventilate via the tracheal lumen. Check for bilateral breath sounds. If breath sounds are unilateral, the DLT is likely inserted too far. The tracheal lumen is inside a bronchus. 2. Inflate the bronchial cuff, 1-2 ml. 3. Clamp the tracheal lumen. Ventilate through the bronchial lumen. Listen for left-sided breath sounds. If right-sided breath sounds persist, the tube is too proximal, still in trachea. Advance the DLT. If only right-sided breath sounds, the tube may be in the right mainstem. Withdraw and redirect into left if no breath sounds over right lung or left upper lobe. The DLT is too deep in the left mainstem. Withdraw slightly. 4. Unclamp the tracheal lumen. 5. Clamp the bronchial lumen. Ventilate through the tracheal lumen. Listen for right-sided breath sounds. If right sounds are absent or decreased, the bronchial cuff is occluding the carina or right bronchus. DLT is not deep enough if right and left breath sounds present. Likely correct. 6. Ensure bilateral equal breath sounds on unclamped mode with both cuffs inflated. 7. Confirm final position via fiber optic bronchoscopy. B. Fiber optic bronchoscopy, gold standard. Fiber optic confirmation is mandatory, especially after DLT placement after patient repositioning supine lateral. If oxygenation or ventilation issues arise, confirmation steps: pass scope down tracheal lumen, visualize carina, both main bronchi tracheal lumen should open above carina, then pass down bronchial lumen. Confirm entry into left main bronchus, make sure left upper lobe orifice is not occluded, right-sided DLT, confirm alignment with right upper lobe slot. See confirmation for bronchial blockers. Visual confirmation via fiber optic bronchoscope is essential steps. 1. Place SLT2. Introduce BB through multiport adapter. 3. Use bronchoscope to guide BB into target main stem bronchus. 4. Inflate balloon and confirm lung collapse visually or clinically. 5. Reconfirm position after turning patient. Note: BBs can migrate easily, especially with head movement or coughing. Frequent reconfirmation is necessary intraoperatively. Adjunctive methods, supportive only, auscultation plus chest rise, can help detect gross misplacement but unreliable alone. Capnography, at CO2 changes may indicate incorrect bronchial placement or cross-contamination. Peak airway pressures, sudden changes can suggest malposition or obstruction. Lung ultrasound advanced use, absence of lung sliding or lung pulse on operative side suggests good collapse. 6. Physiology of one-lung ventilation. OLV. One-lung ventilation is a major physiologic challenge during thoracic anesthesia. The sudden cessation of ventilation to one lung, while perfusion continues to both lungs, creates significant ventilation perfusion (VQ) mismatch, leading to increased intrapulmonary shunt, reduced PAO2 risk of hypoxemia. Ventilation perfusion changes during OLV. Under two-lung ventilation, 55 to 60% of pulmonary blood flow goes to dependent lower lung, 40 to 45% goes to non-dependent upper lung. With OLV, the non-dependent lung is no longer ventilated, but still receives perfusion. Shunt. The dependent lung now receives all ventilation, and ideally most of the perfusion. Shunt. During OLV, shunt fraction increases from 5 to 10%, 20 to 30%. Major determinant of hypoxemia contributes to fall in PAO2, typically within 15 to 30 minutes of starting OLV. 7. Hypoxic pulmonary vasoconstriction. HPV is a protective physiological reflex that helps minimize shunt and preserve oxygenation during OLV. Definition: a locally mediated vasoconstrictive response of pulmonary arterioles to alveolar hypoxia, diverting blood away from non-ventilated hypoxic lung regions toward ventilated regions. Time course: onset within seconds to minutes, peaks within 15 to 30 minutes, gradually adapts but remains active throughout OLV. Effectiveness: HPV can reduce blood flow to non-ventilated lung by up to 50%, may decrease shunt from 30%, 15 to 20%, preserves PAO2 during OLV, especially in healthy lungs. Mechanism: triggered by low alveolar PO2, not PAO2, not centrally mediated, not dependent on neural input, works at the level of small pulmonary arterioles, acts independently on each lung. Local mechanism: see factors affecting HPV. Inhibitors of HPV may worsen hypoxemia. 1. Volatile anesthetics. 1. MAC dose-dependent inhibition, especially isoflurane, sevoflurane. Desflurane also inhibits HPV at high doses. 2. Vasodilators, nitroglycerin, sodium nitroprusside, calcium channel blockers, PDE inhibitors, e.g., milrinone. 3. Alkalosis hypocapnia, blunts HPV response. 4. High PAO2, PAO2, 100 mmHg may paradoxically blunt HPV reflex. 5. Hypothermia, reduces HPV efficacy. 6. Excessive fluid loading, may cause pulmonary edema, worsen VQ mismatch. Enhancers or preservers of HPV, IV anesthetics, TIVA, propofol preserves HPV. Ketamine, hypoxia mild, maintains stimulus for HPV. Normovolemia, moderate hypercapnia. Clinical implications of HPV in OLV. Most patients tolerate OLV with PAO2, 90 mmHg. HPV is less effective in pulmonary hypertension, chronic lung disease, sepsis or inflammation, massive atelectasis or consolidation. Interventions to improve oxygenation during OLV. 1. Increase PAO2 to 100%. 2. Confirm correct tube position. FOB. 3. Suction both lumens. 4. Apply CPAP 5-10 cm H2O to non-dependent lung, if surgical field allows. 5. Apply PEEP 5-10 cm H2O to dependent lung cautiously. 6. Re-expand both lungs intermittently if desaturation persists. 7. Consider inhaled vasodilators. No, prostacyclin, almitrine, not universally available. Adjust anesthesia technique to minimize HPV inhibition. Independent lung ventilation in extreme cases. 8. Anesthetic management during one-lung ventilation. Thoracic anesthesia demands meticulous airway control, lung isolation, and a balanced anesthetic technique that minimizes hypoxia while ensuring adequate depth, immobility, and cardiovascular stability. 1. Induction of anesthesia goals: smooth, controlled induction, avoid coughing, bucking, or sympathetic surges, safe placement of lung isolation device, DLTBB, maintain oxygenation. Drugs and considerations: induction agents, propofol, most common. Etomidate, cardiac patients, ketamine, hypotensive or bronchospastic patients, opioids, fentanyl, remifentanil, blunt sympathetic response to laryngoscopy, muscle relaxants. Rocuronium or vecuronium, avoid succinylcholine, neuromuscular disease or hyperkalemia. Airway strategy: intubation with DLT or SLT plus BB under direct vision. Confirm placement clinically first, then via fiber optic bronchoscopy after intubation. Place patient in lateral decubitus and reconfirm DLT-BB position. 2. Maintenance of anesthesia. Anesthetic technique must support stable hemodynamics, effective HPV, adequate oxygenation during OLV. Volatile agents: isoflurane, sevoflurane, desflurane, usually 1 mg. Volatiles may inhibit HPV at higher doses, still widely used due to titratability and bronchodilation. TIVA, total IV anesthesia, propofol plus remifentanil infusion preserves HPV better. Preferred if neuromonitoring, e.g., MEPS, SSEPs. Patient has severe COPD or PH susceptible to volatilely induced vasodilation. Neuromuscular blockade, maintain paralysis throughout case, prevents coughing, breathing efforts during OLV. Analgesia, multimodal approach: opioids, paracetamol, NSAIDs. Thoracic epidural or PVB if placed pre-op. 3. Ventilatory management during OLV goal: minimize barotrauma and VQ mismatch while maintaining normocapnia. Suggested settings: mode, volume control or pressure control. Tidal volume 5-6 ml/kg of ideal body weight. FiO2, start at 100%, titrate down if safe. Respiratory rate, adjust to maintain ETCO 235-40 mmHg. 5-10 cm H2O to dependent lung I, E ratio, 1, 2. Limit plateau pressure, 25 cm H2O. Key points: avoid auto PEEP, lengthen expiratory time, avoid large tidal volumes, can worsen lung injury. CPAP to non-dependent lung if needed and tolerated surgically. 4. Fluid management. Thoracic surgery patients are vulnerable to pulmonary edema, right ventricular dysfunction, re-expansion, lung injury. Principles: restrictive fluid strategy, maintain euvolemia, use vasopressors, phenylephrine, norepinephrine. If needed, crystalloids preferred, avoid colloids unless justified, avoid fluid boluses during lung re-expansion. 5. Monitoring during OLV: SPO2 and ETCO2, continuous arterial line, for beat-to-beat BP, ABGs. Neuromuscular monitoring, ensure paralysis, peak and plateau pressures, track lung compliance. ABGs. Baseline after induction: 15 to 20 minutes after starting OLV as needed for hypoxia. 6. Emergence and extubation: fully re-expand the collapsed lung before closure, use hand ventilation or manual inflation, avoid forceful, rapid reinflation to prevent re-expansion. Pulmonary edema: suction both lumens, ensure normothermia. Adequate reversal, spontaneous effort, smooth emergence critical, coughing can rupture. Surgical anastomosis. Extubation considerations: DLT converted to SLT if post-op, mechanical ventilation expected. Extubate on table if normoxia. Normocapnia: full reversal of NMB, intact airway reflexes and good respiratory drive. 9. Awake thoracic procedures. Traditionally, thoracic surgeries require general anesthesia with muscle relaxation in OLV. However, in select cases, certain thoracic procedures can be performed under regional anesthesia with spontaneous ventilation, often in awake or sedated patients. 1. Awake thoracotomy. Awake VATs, video-assisted thoracoscopic surgery. These are performed in spontaneously breathing patients using regional techniques: epidural, paravertebral, or intercostal blocks, minimal or moderate sedation. Dexmedetomidine, remifentanil, or low-dose propofol, supplemental oxygen, face mask, nasal cannula, high flow. Indications: severe comorbidities, e.g., severe COPD, frailty, poor cardiac reserve. Procedures where spontaneous breathing is desirable: bilateral procedures or short resections, e.g., wedge resection. Patients with contraindications to GA or intubation. Techniques: Lateral decubitus position sedation titrated carefully to preserve respiratory drive. Analgesia via thoracic epidural paravertebral block ESP block local anesthesia at trocar sites VATs. Advantages: avoids GA, intubation. Muscle relaxants preserves diaphragmatic and intercostal function, reduces postoperative respiratory complications, quicker recovery and shorter hospital stay. Disadvantages: requires cooperative, pain tolerant patient. Surgical exposure may be suboptimal. Risk of coughing, paradoxical movement, or panic. Airway backup plan must always be available. DLT or BB2. Non-intubated VATs. NIVATs, evolving concept involving spontaneous ventilation under sedation without endotracheal intubation. Features: uses regional block, PVB or ESP plus or minus local at incision site, spontaneous breathing width, nasal cannula LMAHFNC, high flow nasal cannula, lung collapse facilitated by surgical pneumothorax, entry into pleura, CO2 insufflation, rare. Concerns: surgical field motion from respiration desaturation due to hypoventilation or VQ mismatch, hypercapnia, airway obstruction, aspiration. Postoperative management. Patients undergoing thoracic surgery are at high risk for postoperative respiratory compromise, pain, and complications. A comprehensive plan is essential. 1. Lung re-expansion. Ensure complete and controlled re-expansion of operative lung before closure. Avoid vigorous or rapid reinflation. Risk of re-expansion, pulmonary edema, barotrauma, suction both lumens before extubation. 2. Pain control. Post-thoracotomy pain is among the most severe and interferes with deep breathing. Effective coughing. Early mobilization. Preferred techniques. 1. Thoracic epidural analgesia, T, gold standard continuous infusion of 0.1 to 0.125% bupivacaine plus fentanyl, 2-5 mcg/ml. Benefits: reduced atelectasis, pneumonia, improved VQ2. Paravertebral block, PVB, alternative to epidural. Similar analgesia with lower hypotension risk, may be single shot or catheter-based. 3. Erect or spiny plane ESP block, safe, simple, ultrasound-guided, effective for both open and VATs. 4. Intercostal nerve blocks, useful if epidural PVB not feasible, require multiple level injections, shorter duration. 5. Multimodal analgesia, IV paracetamol and NSAIDs if renal GI status permits, gabapentinoids, PCA opioids as backup. 3. Respiratory support, supplemental humidified oxygen incentive, spirometry and chest physiotherapy, nebulized bronchodilators plus or minus mucolytics, non-invasive ventilation or CPAP in select cases, early mobilization and ambulation. 4. Monitoring and drains, close observation. 4. Hypoxia, tachypnea, air leak from chest tube infection or bleeding, chest drains connected to underwater seal or suction system output, bubbling, air leak, and lung expansion monitored regularly. 5. Common postoperative complications: pulmonary, atelectasis, pneumonia, bronchospasm, respiratory failure, re-expansion, pulmonary edema, cardiac, atrial fibrillation especially post-pneumonectomy, myocardial ischemia, surgical, bleeding, air leak, bronchopleural fistula, phrenic or RLN injuries. Anesthesia for special thoracic procedures. These procedures pose unique challenges in airway, ventilation, and hemodynamics. Mastery of their anesthetic implications is critical for long case performance. 1. Pneumonectomy definition: surgical removal of an entire lung. Preoperative considerations: high physiologic burden, requires extensive workup, perform full PFTs. Calculate PPO-FEV1 and PPO-DLCO-VO2 max. Preferred in borderline patients. CT chest plus echo screen for PH and RV dysfunction. PPO-FEV1 and PPO-DLCO, 40% increased risk, 30% very high risk. Intraoperative considerations: use left sided DLT for right pneumonectomy unless contraindicated. Avoid fluid overload. Use vasopressors instead of liberal fluid. Monitor ABGs, plateau pressures, and hemodynamics closely. Maintain low VT, low PEEP. And normocapnia. Controlled hypotension may be needed for hilar dissection. Postoperative risks: post-pneumonectomy, pulmonary edema, PPE. Most feared complication: high mortality, presence 24-48H post-op with sudden hypoxia. Pink frothy sputum. Avoid fluid overload. 2L day recommended. Arrhythmias AF common, RV dysfunction and failure, respiratory insufficiency, prolonged ventilation. 2. Bronchopleural fistula BPF. Definition: pathologic communication between the bronchial tree and pleural space. Etiology: post-lobectomy pneumonectomy necrotizing infections TB, empyema, trauma, tumor erosion. Anesthetic goals: prevent contamination of healthy lung. DLT mandatory. Minimize air leak and barotrauma. Absolute indication for lung isolation. Ventilation strategy: use low tidal volumes, short I/E ratio. Avoid high airway pressures. Avoid N2O. Expands air in fistula may require independent lung ventilation if severe. Special caution: avoid mask ventilation pre-induction if large BPF suspected may cause massive air leak or pneumothorax. 3. Tracheal resection and reconstruction. Shared airway cases require perfect coordination between surgeon and anesthetist. Anesthetic challenges: maintaining oxygenation and ventilation during open airway phase, preventing tension on anastomosis post-reconstruction. Ventilation options: jet ventilation through small catheter, apneic oxygenation, intermittently cross-field ventilation. Surgeons place sterile ED into distal trachea, HFNC, or spontaneous breathing during early stages. Emergence: neck flexed post. Opt to reduce tension. Avoid coughing. Risk of dehiscence. Reinforced tube may be used. Extubation may be delayed in high-risk cases. 4. Mediastinoscopy, used for biopsy of mediastinal lymph nodes masses. Key concerns: large vessels and trachea in tight space. Risk of innominate artery compression, vascular injury, tamponade, pneumothorax, air embolism, arrhythmias. Vagal or direct stimulation. Anesthetic considerations: GA with muscle relaxation. Short procedure. IV induction plus LMA. Often used. Right radial arterial line. If innominate artery is compressed, right BP drops. 5. Lung transplantation, one of the most complex thoracic procedures. Preoperative: profound hypoxemia may already be on. High flow oxygen inhaled. No ECMO. Intraoperative goals: maintain RV function, control pH and oxygenation. Prepare for massive transfusion. Use DLT for OLV until native lung removed. May require CPB or ECMO intraoperatively. Postoperative concerns: primary graft dysfunction, PGD. Acute lung injury post-transplant. Immunosuppression. High infection risk. Long-term rejection risk. 6. VATS thoracoscopy, minimally invasive thoracic surgery technique. Advantages: smaller incisions, less postoperative pain, lower incidence of respiratory complications. Anesthetic considerations: OLV is still required. DLT or BB. CO2 insufflation sometimes used to collapse lung. Same physiologic principles as open thoracotomy. 12. Intraoperative troubleshooting during OLV. Thoracic anesthesia often requires rapid recognition and correction of events like desaturation, high pressures, or ventilation failure. Here's a stepwise, exam-perfect guide. 1. Desaturation during OLV, SPO2, 90%. Stepwise algorithm. A. Mechanical check. Always first reconfirm DLT or BB position with fiberoptic bronchoscope. Check for malposition, obstruction, herniated cuff suction. Both lumens. B. Optimize ventilation to dependent lung. FiO2 100%. Confirm TV 5-6 ml/kg. IBW. Increase RR if needed. Avoid hypercapnia. PEEP to dependent lung. 5-10 cm H2O. C. Re-expand or support non-dependent lung. Apply CPAP 5-10 cm H2O to non-ventilated lung, if surgical field allows. Intermittent to lung ventilation if persistent desaturation. D. Manage contributing factors. Minimize volatile agent. To preserve HPV, avoid alkalosis, vasodilators, excessive fluids. Consider inhaled nitric oxide, almitrine, if available. 2. High peak airway pressures causes mucus plug or secretions. Suction. Both lumens. Tube kink or obstruction. Main stem intubation or overinflation of bronchial cuff. Bronchospasm. Deepening anesthesia. Bronchodilator. External compression. Surgical retraction. 3. Incomplete collapse of non-dependent lung. Causes and solutions: BB or DLT not properly placed. Check with bronchoscope. Suction operative lung, via bronchial lumen or BB port. Clamp earlier before incision to allow deflation. CO2 insufflation may assist in VATs if allowed. 4. Hemodynamic instability causes high intrathoracic pressure, PEEP, CPAP. Hypovolemia, common due to restrictive fluids, surgical compression of heart or vessels. Tension. Pneumothorax management: reduce PEEP if causing hypotension. Trendelenburg or slight head down if preload sensitive. Start vasopressors, phenylephrine, norepinephrine. Bolus small aliquots of fluid if clearly hypovolemic. Alert surgeon to pause and reassess field. 5. Re-expansion pulmonary edema occurs when a chronically collapsed lung is rapidly reinflated with positive pressure, particularly post-pneumonectomy or lobectomy. Prevention: avoid forceful, rapid re-expansion. Use manual reinflation under vision. Slowly treatment: supportive, high FiO2 PEEP diuretics if indicated may require reintubation. Mechanical ventilation. 6. Sudden hypoxia post-positioning. Always suspect DLT migration or kink. Reconfirm with bronchoscopy. Rule out compression or dislodgement of BB double lumen tube. DLT size estimation. 1. French size, FR, basics. French size refers to outer diameter. 1 FR equals 0.33 mm. Therefore, 3 FR equals 1 mm. 2. Inner dia versus outer diameter. If inner diameter ID equals 6 mm, then outer diameter OD 8-9 mm. 3. Tracheal dimensions: length 10-12 cm, diameter 15-20 mm. 4. Fiber optic bronchoscope. FOB minimum. FOB outer diameter required 4 mm, suitable for size 35-41 FR DLTs. 5. Depth of insertion formula, plus 12.5. Example, height equals 160 cm, depth equals 160%. 10 plus 12.5 equals 28.5 cm. 6. DLT size based on tracheal diameter. 7. DLT size based on height and gender. Female, height, 160 cm 37 FR. Height, 160 cm 35 FR. Male, height, 170 cm 41 FR. Height, 170 cm 39 FR. 8. Best method for DLT sizing: use left main stem LMS bronchus diameter on CT scan. CT scan.